ladies and gentlemen, Mr. Chairman, it's a privilege to follow First Lady Mrs. Bush in talking about an important way of improving the health of women and men by treating cholesterol. Now, we know from multiple trials over the past decade that lipid-lowering therapy with statins is highly effective versus placebo in the long-term management of a wide variety of patients with coronary heart disease. But two questions have remained. First, are statins effective in reducing cardiac events when started early after an acute coronary syndrome? And second, among people receiving active statin therapy, does intensive lowering of LDL cholesterol to a level of about 65 confer added reduction in benefit and clinical risk when compared with the current standard of getting LDL below 100? And so we addressed this in the Prove It TIMI-22 trial, where we randomized 4,162 patients who had been hospitalized for an acute coronary syndrome within the last 10 days. All patients received aspirin and standard medical and interventional therapy for their acute coronary syndrome. And in a double-blind fashion, were randomized to two different levels of lipid lowering. A standard therapy matching the guidelines, we used pravastatin 40 milligrams. And the intensive therapy, we used atorvastatin 80 milligrams to get the lowest possible level in LDL cholesterol. In a 2x2 factorial design, we also studied an antibiotic as compared with placebo, the results of which are not yet complete and I will not cover today. The duration of treatment and follow-up on average was 2 years and was such in the trial that we collected at least 925 events before performing the follow-up visits in all patients. And we ended up with 1,001 events in this trial. And the primary endpoint was a 5-part composite including all-cause mortality, myocardial infarction, unstable angina with documented evidence of ischemia that required rehospitalization, revascularization performed at least 30 days after the initial index event, and stroke. The details of the patient population are illustrated here. Patients had to be hospitalized for an acute MI or unstable angina with other high-risk features within the last 10 days. They had to have a total cholesterol of less than 240, or if they were receiving lipid-lowering therapy, a total cholesterol of less than 200, measured within the first 24 hours of their hospital admission. They also were enrolled after being stabilized, that is, they were without ischemia, heart failure, and were following a percutaneous coronary intervention if performed. Major exclusion criteria included other major comorbidity, therapy with high-dose statin at baseline, need or anticipated need for fibrates or niacin, and thus this trial looked at patients only being treated with statins. If patients were going to be managed with coronary artery bypass surgery for the treatment of their initial index event, they were excluded. Liver disease and unexplained creatine kinase elevations were an exclusion. And patients who were taking strong inhibitors of the cytochrome P450 enzyme 3A4 were excluded because that is the way that atorvastatin is metabolized. The 4,162 patients were enrolled at 349 centers worldwide in the 8 countries that are illustrated here, and the national investigators for each of the countries is listed as shown. The top 10 enrolling centers of the more than 800 investigators and research coordinators illustrated here, and this is the results of this trial are the result of their hard work over the last 3.5 years. The study was conducted under the chairmanship of my mentor, Dr. Eugene Braunwald, and under the direction of Carolyn McCabe in the TIMI study group. Data coordination was carried out by the Nottingham Clinical Research Center under the direction of Dr. Alan Skeen. The sponsors of this trial were both Bristol Myers Squibb and Sankyo, and the Clinical Events Committee was chaired by Dr. Mark Pfeffer. The baseline characteristics of the patients are illustrated here. Our mean age was 58, and we had about a quarter of the patients were women. About 20% had diabetes, And of the type of acute coronary syndrome, it was evenly divided, with 1/3 of the patients having ST segment elevation MI, 1/3 with non-ST elevation MI, and 1/3 with unstable angina. And 1/4 of the patients were receiving statin therapy at the time of their index event that then was switched to study therapy. These patients also were managed with an early invasive strategy, such that 69% of the population had undergone percutaneous coronary intervention prior to randomization in response to their initial acute coronary syndrome. And then during the treatment of the trial, the patients received 1 or sometimes 2 antithrombotic agents with aspirin, warfarin, and/or clopidogrel during the follow-up period. 85% of patients were treated with beta blockers, and 83% of patients were treated with ACE inhibitors or angiotensin receptor blockers. And thus, these patients received optimal medical and interventional therapy. In the 2 randomized arms, we sought out to seek 2 different levels of cholesterol lowering. And illustrated here are the changes in the LDL cholesterol from baseline. And so beginning here, measured within the first 24 hours, is the LDL cholesterol of 116 that then fell, as has been seen in all patients with acute coronary syndromes, to 106 at baseline at the time of randomization. With standard therapy, this was reduced by 21% and achieved a median LDL of 95, thus matching the goal of being less than 100 according to our current national guidelines. In the intensive lipid-lowering therapy, this was reduced by 49% and achieved a median LDL of 62, with the interquartile range ranging from 50 to 80. And so the question has been, in patients getting active therapy that meets our current guidelines, is it important to lower the cholesterol even further? So the answer is yes. We saw that compared with gold standard treatment with a validated level of lipid lowering, that more intensive lipid lowering with atorvastatin 80 milligrams was associated with a 16% reduction in the risk of all-cause mortality or major cardiovascular events. This was a highly significant difference with a p-value of 0.005. Now, the benefit that was observed with more intensive lowering of the lipids was seen very early, so that at just 30 days, the risk reduction in the hazard during follow-up to that point was already 17% lower. And this was consistently seen over the entire follow-up period, that there was an early and ongoing benefit of more intensive lipid-lowering therapy. Now, another harder endpoint of a 3-part endpoint of death, MI, or the need for urgent revascularization is illustrated here. This too was significantly reduced by 25% with the more intensive therapy, a p-value of 0.0004. Other individual components of the endpoint are illustrated here. All-cause mortality was reduced over the treatment period during follow-up by 28%. This p-value was 0.07, and thus of borderline statistical significance. The rates of mortality at 2 years were 3.2% as compared with 2.2% in the standard treatment arm. Coronary heart disease death, myocardial infarction, the combination of death or MI, the need for revascularization, and rehospitalization for unstable angina were all reduced in a similar fashion between 15 and 30%. For the endpoint of stroke, we did not see a difference between standard statin therapy as compared with more intensive statin therapy, but there were fortunately very few events in patients who had stroke, and thus the confidence intervals are wide. Here is the primary endpoint illustrated in major subgroups, and I want to highlight here with the importance of treating heart disease in women, the 22% of this group who were women, they had a significant reduction with more intensive lowering of lipid lowering, with event rates at 2 years going from 27% down to just over 20%. So 7 women out of every 100 treated with more intensive therapy after going home from the hospital for an acute coronary syndrome had fewer events. Similarly, patients with diabetes or no diabetes, elderly or younger patients, and those with different levels of high-density lipoprotein cholesterol all had a similar reduction that was not different in the subgroups analyzed. The one subgroup of the 19 that we examined that did show a greater benefit was patients with an LDL cholesterol of over 125, where it was a 34% risk reduction in the hazard over the period of time, and a lesser benefit in those with a lower cholesterol. On the safety profile of these two strategies, we did observe that there were more patients who had elevations of liver enzymes with the more intensive therapy, 3.3% as compared with 1.1% for patients treated with pravastatin 40 milligrams, a significant difference. On the other hand, elevations in creatine kinase or discontinuation of study medication for myalgias or elevations in creatine kinase were similar between the two treatment groups. And so to summarize, we studied patients who had recently been hospitalized for an acute coronary syndrome. And we saw that intensive lipid lowering with high-dose statins to a median LDL of 62 significantly reduced the risk of all-cause mortality or major cardiac events by 16% as compared with the current standard dose lipid lowering therapy that did achieve a median LDL below our current guideline recommendations, a highly significant difference. These benefits emerged within 30 days after the acute coronary syndrome and continued over the 2.5-year period with a constant 16% relative benefit favoring more intensive therapy. And these were consistent across all of the cardiovascular endpoints with the exception of stroke and in most of the clinical subgroups, and highlighting today as well in women. And so, as published now this morning in the New England Journal of Medicine, we conclude that our findings indicate that patients recently hospitalized for an acute coronary syndrome benefit from early and continued lowering of LDL cholesterol to levels substantially below current target levels. And I think more broadly, for all patients with cardiovascular disease, the results of PROVE-IT-TIMI 22 emphasize the central role of lowering LDL cholesterol for the treatment and prevention of mortality and morbidity from heart disease. Thank you very much for your attention.
Thank you, Dr. Cannon. You didn't disclose any conflict of interest. Shall we assume that we have no conflict of interest in presenting this data?
Please put up my first slide. I did list all of my conflicts of interest on the first slide as usually requested.
Thank you. We have time for one question from the floor. If there is no question, I've got one for you. You showed very clearly that in patients with initial LDL cholesterol below 125, there is apparently no significant difference in the outcome as compared to patients with more than 25 LDL cholesterol. It's a bit in discrepancy with other previous reports in different settings like HPS study, for example, where there is a consistent risk reduction for the long-term outcome, whatever is the initial blood cholesterol and LDL cholesterol. Could you comment on this, please?
This is a very good observation. I think we have seen in the heart protection study that in patients at risk for heart disease, treatment with a standard dose of a statin lowers the risk substantially. We use that as the baseline therapy, and we sought to ask the question, if you go even further down in the LDL cholesterol is that of benefit. And so in the lowest group of patients with the low cholesterol, the achieved cholesterol was actually 87 in patients receiving standard therapy. And when that was taken down to 50, there didn't appear to be a big difference in that subgroup of patients. However, taken together, the studies again reaffirm the importance of, from other trials, establishing that statin therapy reduces the risk of all cardiac endpoints relative to placebo. And we see today across a wide variety of subgroups of patients that further lowering of LDL cholesterol can lead to added benefit. Thank you very much for your attention.
We have got one question on the floor. Just one question, please.
Since the chairman permits a question, Professor Cleland Kingston, Hull, UK, over here. I was astonished to see a 2-year mortality down at 2 to 3% for these high-risk unstable angina post-MI, which leads to the question of how representative this patient population is to patients having MI. It was a relatively young population. It seems a very low-risk population to begin with.
Well, this is a very good point. I should emphasize that we enrolled patients at the time of hospital discharge. So during hospitalization, the mortality tends to be about 4 or 5% in patients with acute coronary syndromes and other cardiac events also as well. We enrolled patients, and thus the start of the event rates is at the time of hospital discharge. Now, these patients were also very intensively treated both with interventional therapy and every single secondary preventive medication at very high levels. And thus, we feel that this offers an insight into the optimally managed patient. We see the added benefit of the further lowering of LDL cholesterol in these high-risk patients. But again, this begins following hospital discharge and is exactly what we had estimated from all of our prior trials in terms of the event rates. And so it's different from other trials that enroll at the time of admission. This is begun therapy at the time of hospital discharge. So I think this tells us as cardiologists that when we have patients going home after an acute coronary syndrome, that we need to use early and intensive lipid-lowering therapy to try and prevent even further the rate of mortality and cardiac events as compared with standard therapy with statins.
Thank you, Dr. Cannon.
Thank you very much.